Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Welcome to another episode of the Research Works podcast.
Welcome, everyone. It's so nice to be in the studio today with an in-studio guest.
Yes.
We're pretty lucky, actually, because we've been trying to coordinate times because very busy person and for a very good reason.
Absolutely. Yeah. It feels like a very special treat because we have someone in studio,
yes,
which we always get very excited about.
Yes.
But that person is Professor Nick Gottardo from Perth Children's Hospital and the Kids Research Institute Australia. Welcome, Dr. Nick.
Oh, thank you. Thank you. It's a privilege to be here. Thank you.
Oh, it's lovely to have you here. And I think the fact that, should we just call you Dr. Nick? Because that's what you're known by.
Yes.
Everywhere we go, right?
Yeah,
yes.
yeah.
Okay. So that's the formalities. Dr. Nick.
Yeah.
But there's good reason why we're so excited to have this conversation with you today.
For sure.
Yeah.
And I think, once we read out your bio, everyone will have a greater appreciation of why that is. So for our listeners, if you're not familiar with Professor Nick Gottardo, he is the co-lead of the Brain Tumour Research Program at the Kids Research Institute Australia. He's also the head of Paediatric and Adolescent Oncology, Haematology Department and the Stan Perrin Chair in Paediatric Oncology and Haematology at Perth Children's Hospital. Nick is also the chair of the Australian and New Zealand Children's Haematology Oncology Group, the peak professional body for paediatric oncologists and health professionals who care for children with cancer, and the National Cooperative Clinical Trials Group for Childhood Cancer. He leads several international clinical trials, including the frontline clinical trial for WNT subgroup medulloblastoma patients for the US Children's Oncology Group. He also sits on the executive and steering committees for the Collaborative Network for Neuro-Oncology Clinical Trials, or CONNECT Collaborative, an international paediatric neuro-oncology clinical trials group.
Well done. That was really impressive. That
Not
was
as
so
impressive
good.
as Dr. Nick.
Oh my gosh, yes.
I'm sorry, that's a real too many titles.
That's okay. I think it just speaks to, how many different hats you wear and how impressive the work is that you and your team do.
Yeah. And also speaks to all of your networks as well, which will, as we talk about today, will be so obvious, isn't it? You can't do this kind of work on your own. It's no such thing.
No, the key is really collaboration. And because we're so isolated in Perth, it's doubly important.
That's right. That's right. That's why it was really worthwhile going through all the connections because that's important.
Absolutely.
Yeah.
So, Dr. Nick, that's our formal getting to know you. We also like to do an informal getting to know you here on Research Works. And our informal getting to know you or icebreaker question today is, if your life had a theme song, what would it be?
That's a good question.
Do you know, I'm not right into music. I might struggle to come up with an answer with titles. Like, I know the tunes and I like listening to tunes.
Oh, we're happy
but
with
I
the
often
tunes.
don't know who sings it and what the title is.
This is a good game.
You could give us a few lines and we could try and guess.
Can you hum the tune or sing it?
I've got to think of it first.
That's all right. I can give you mine while you have a think on it. Because as I was saying off mic to Dana and Dr. Nick, it was quite a process getting here this morning for recording. There were lots of different pieces of the puzzle that had to come together and fall into place. And so while I was driving to the studio, I was singing in my head a little Elton John song.
Really? What was it?
I'm Still Standing.
That is perfect.
Well, it was very appropriate for the moment. Yes.
Absolutely.
That's such a good one. Okay, well, I can follow from this one because what you're wearing today also triggers me because I am, yes. And when this song gets stuck in my head, it will be stuck in my head for days. So it's going to start now anyway. But whenever I see black and white or two contrasting things, all I can hear is ebony and ivory live together in perfect harmony. I can't help it. It has to go through the whole thing. And my head just has to sing it. I've got two dogs. One's white, one's black. And I didn't even do it intentionally. Like it was one day I saw them walking along and I'm like, I got a black and a white dog, ebony and ivory. And so I just sing that. So it's a Paul McCartney, I think. Paul McCartney?
Oh,
Ed? Producer Ed? I don't know.
But you sang it well.
It was beautiful.
It's because it goes on in my head. So when I do see two contrasting things, it starts for no other reason than it just triggers it.
And
isn't it bizarre?
Before you started singing, I really thought you were going to do Michael Jackson.
I could tell by you looking in your face. Look, that one also is a great one as well. But it's always the one that comes after. It's always Ebony and Ivory. And I don't know why.
I'm really sorry. I'll be more mindful of that in the future.
I love how it wasn't even planned, but it triggered anyway.
Well, my wife's a real fan of ABBA. And so I do hear those music
that gets
playing.
Stuck in your head.
And I guess the one that resonates is money, money, money. Because I'm constantly trying to bring money in to do the work that we do, particularly around the clinical trials and the research.
That's a good one.
Yeah,
that's a true
that one that just came to my mind.
Yeah.
I love that.
I'll go with that.
And we also love answers to icebreaker questions that are the perfect segue into the topics that we're going to talk about. So you get double points.
Yeah.
There you go.
Thank you. Well done. Yeah. We can definitely bring that one back in.
For sure. Everyone loves an origin story, don't they?
Oh, yes, please.
And I think it would be really worthwhile for our listeners to hear more about you and how you came to find yourself in this field and doing the work that you do. Where did it start?
Yeah, I often rack my own brain to know, why. I think it probably goes back to my childhood, but more recent. So when you're training to be a pediatrician, which I was training at what was then Princess Margaret Hospital, is now Perth Children's Hospital. I loved all aspects of pediatrics, and but during my rotation, I had to do a term in oncology for 6 months, and there I fell in love with the specialty. I'd looked after some incredible patients, and there was one boy in particular, Kyle Andrews, who I was privileged to look after. He passed away from a T-cell leukemia, and in fact, he really inspired me to work in the field. And I actually did my PhD in T-cell leukemia to try and find avenues for better cures. So I think it was really working on that unit and being exposed to amazing people that were doing amazing work, and moreover the children I worked with, the inspiration that I gained from them. And this little boy, like I said, was quite instrumental. I then wondered to myself, where did that sort of wanting to then dedicate your life to that area? And there was an incident when I was very young, because I grew up in Italy. I grew up in a very little village in the north of Italy, in the mountains, Lombardy region. The name of the village is tiny. It was called Sondalo. My dad used to run a hotel there.
Wow.
And my dad was a blood donor.
Right.
And we had, although it was a small village, it had a disproportionately large hospital that had been built by Mussolini, actually, in the 30s.
Wow.
To look after TB patients, because the high altitude was about the only treatment that was in fresh air for TB, because they didn't have the anti-TB drugs back then.
Okay.
Of course.
And so a lot of people used to come to this village and then be looked after in this hospital. But of course, once TB drugs became available, it no longer was required for TB, but was still quite a large hospital for the size of the town. Anyway, to cut a long story short, there was a little girl who was a couple of years older than me, and I would have been 5 or 6 years old, and she would have been 7 or 8 maybe, and she had leukemia.
Right.
And I still to this day remember vividly, it was the middle of the night, and my father receiving a phone call to go urgently to the hospital to donate blood.
Wow.
Because this child was bleeding.
Yeah.
And I think that left an impression on me. And he came back and he was devastated because she'd passed away. And I think he felt, I don't know, that he didn't help her or whatever. And to this day, my dad's 77, he carries a picture of her in his wallet.
Oh, my goodness.
To this day.
Wow.
And And I sort of think if she'd been born in this era, she almost certainly would still be alive, and she would have grown up to have a full life. I mean, she'd obviously, I'm 54, she would have been like 57 or something like that. Yeah. So I wonder whether that was the root that was, or the seed that was sown, that then was, if you like, then grew when I did my time on the unit. Because it always struck me that through advances in research that we can make a big difference for these children who are fighting incredibly aggressive diseases. So I think that, if that gives a...
I think that's a beautiful origin story. Yeah.
That's a great origin story.
Yeah, and thank you for sharing it with us as well. Yeah.
I think it also, when I sit and think about these things all the time just because that's what I do. And when I think of ebony and ivory and I think of all these things that come into my head, passion and perseverance are like the two words that always come up for me. And when you are passionate about something, and that usually is a trigger as a story, like stories really guide you on that path, and that perseverance of trying to find a solution. You need people in this world that are willing to do that. Like I had a parent here the other day say to me, "Man, Dana, you don't have a life." I'm like, well, this is my life's work. It is, it is my absolute passion and desire to do so. And, and I'm so happy for that. I'm so grateful that there's people like you, Nick, that, has that passion and drive and perseverance, because it isn't easy. It isn't an easy ride.
No, it definitely has its trials and tribulations. There's no doubt about that. But by far the rewards outdo the challenges. It is a very rewarding area to work, but it's obviously not for everyone. But the people that have made it, their careers and their, like you said, their passions, they don't want to do anything else. And once you get into it, you just want to make it better for these kids, because it's not right that, I mean, one of my youngest patients, I did a telehealth with him yesterday. He's gone home now. He's just finished a grueling amount of treatment, but he's 16 months now. He's been in hospital. He was in hospital from 4 months of age.
Wow.
That's not right.
No.
We've got to do something about that. And hopefully we've got him and he's going to be okay. And it's lovely because, he can, look, because I've not seen him for a couple of months because I've been on long service leave, and his hair's grown back and he looks like a little boy now rather than a little baby. And you think, well, and his parents are so happy to be home and everything, and it's just lovely to see that.
Really beautiful.
But when you go back and think, why does a 4-month-old get brain cancer? What's going on?
Well, that's the perfect segue to talk about what we'd love to ask you more about. As clinicians, we often see the other side of it, from the survivorship perspective, and you see the symptoms, but actually understanding it from its origins is probably really useful. And we thought, let's talk about medulloblastomas. We know that it probably accounts for around 20%. I don't know if those stats are still accurate. So I thought, can we dive into that? Can we understand a little bit more from you? What is childhood brain cancer? It's a very broad term, and we went to a brain cancer ball last year. And you celebrate the people who are in this community. But to understand it more, I think it would be great to have a bit more background. Do you mind walking us through?
Sure.
What do we see and signs and symptoms? And
So brain cancer is very broad. There are over 100 different types of brain cancers, and then when you go down to the molecular level, one diagnosis can give you, up to 17 different subtypes of that same disease. Medulloblastoma is the prime example. By and large, most brain cancers of childhood are developmental disorders.
Right.
In fact, if not all.
Okay.
So in other words, they are processes that the brain uses to develop itself. So they're genetic programs that have gone awry. So either through mutations or gene deletions, amplifications. There are a whole host of ways a gene can be altered. And the other one is through deregulation of something called the epigenome, which controls genes to go up and down without altering the actual gene itself. So it's like the environment. So medulloblastoma is actually a really good example that I can use to explain these developmental pathways that have gone wrong. Because obviously the brain of a newborn child is very, very premature. And how do we know that? Well, when a baby is born, he or she is 100% dependent on the parents. But what you will see over the child's first few months is they start to do more. And the first things, one of the first developmental milestones is they smile, which is felt to be a survival mechanism because it's very hard looking after babies when they cry and need so much. But when they smile, it melts hearts, doesn't it? It's that human connection. And so that, as opposed to a gazelle that's born and has to be able to run immediately because the gazelle is going to be potentially eaten. So the gazelle has to be they've compromised intelligence, the big brain, the intelligence brain, and all the consciousness, all the things that make us human for the ability to evade being eaten.
Right.
Whereas we're the opposite. Our cerebellums are born very, very rudimentary, and we've got the big forebrain, which then will go on to make us what we are, and with intelligence. And all the qualities that make humans different to the animal kingdom. And so these pathways then need to be developed as the child is growing. So the cerebellum developing is very obvious to see as a child is growing in the first year because most babies, the first things they'll start to do then is they'll start to be able to roll or roll over, then they'll be able to sit up, then eventually they'll be able to pull up, then they'll be eventually cruise around furniture, and then finally be able to walk by themselves, but still rudimentary because when a child walks, the gait is very broad-based because they're not very steady, and eventually it becomes more refined, and then they can run, jump, and walk, tight ropes and all of those things as the cerebellum has developed.
Sure.
The cerebellum is where medulloblastoma originates from.
Right.
There are different types of medulloblastoma, but I'll focus on one type that comes from the cerebellum. And so these pathways then are, so genes are switched on so that this part of the brain can develop rapidly over the months, and then they need to be switched off because you don't need those cells to be proliferating once you've developed what you've developed. And then, so a cell will need to grow, make many of itself, and then it needs to differentiate. In other words, become different types of cells that have got different functions. Because it's very complex, the brain, obviously. And if there's a mutation in one of these key genes that is used by the brain to develop the cerebellum, it can form a cancer. And that cancer in those cells, if the pathway, and the pathway I'm talking about is called the sonic hedgehog pathway, it can, from just a simple one mutation, it means those cells stay on when they should be switched off or differentiate. They remain primitive and highly proliferated, and then eventually they will take over. And the cancer is born. Because it's just an uncontrolled process. It has no ability to know when to stop because the mechanisms have been hijacked because of this mutation. And there are mutations in gene known as the sonic hedgehog pathway. We now know that we've dissected this, and some of these are actually inherited. So you can pass them down through generations. And that is probably one of the best examples to highlight how children's brain cancer really is it's a developmental disorder. But and many childhood cancers are, because kids' cancer and adult cancer, they share the name cancer, but that's pretty much where the similarities end. Adults get cancers often from, they're not developmental, they're often from environmental exposures or mistakes that happen just because of aging. So a cell has all these genes that are there to protect it, and if it goes funny, it sort of self-destructs. If those things start not to work and the cell's repair mechanisms aren't so good, then it can become cancerous. And that's why the incidence of cancer increases. And so, there are thousands of adults with cancer and only a few hundred children, like in Perth. As you know, we have about 120, somewhere between 110 and 120 new patients per year, which is way too many. But when you compare it to adult cancer, you've got thousands.
Sure.
And that's because that process of for the adults is as you age, your incidence increases because mistakes become more frequent as the body is not as good at picking errors up.
Right. Wow.
So does that help explain a little bit?
I feel like
that was the best masterclass right there.
100%. 100%. And Dr. Nick, it's got me thinking about, because it is a developmental a problem with something that's happening in development. Is there acknowledging there's variability in this, is there a typical age that you might start to see things like medulloblastoma occurring?
So we do. So it's mostly a disease of childhood, which makes sense if it's a developmental disorder, but not exclusively. It has different peaks. So for sonic hedgehog, not surprisingly, the common type you get it is when you're an infant, because that's when these processes, and of course, I've described that it goes wrong, but these bad cells can lay dormant as well, and they can pop up later. Okay, so it may be that, and we don't fully understand. So it's very easy to what I've talked about, and then say, well, it's the babies that are going to get it. And in fact, one peak for this sonic hedgehog medulloblastoma is babies. In fact, a dear colleague of mine who runs the Connect collaborative group, she actually emailed me last night and some other people saying, I'm giving advice to a doctor in Turkey about this child with sonic hedgehog medulloblastoma. What do you think? What would you do in this sort of circumstance? So it goes to show it's a universal and it's a little young child. And so that makes sense. But the other peak is in adolescence, and young adults. So you'd think, well, how does that work when it's a developmental disorder? Well, we don't really know, but one hypothesis we have is really around this. Yes, the tumor was formed way earlier, but laid dormant, or the immune system was able to keep it in check until something awakens it or triggers it to come. So the common age is young children. Sort of, if you looked at, and medulloblastoma is composed of 4 main subgroups, which we now know they're all, 2 of them are very well described in what they're driven by, and they're abnormalities in these developmental disorders. One, the sonic hedgehog. The other one is the one that I ran, that clinical trial that you mentioned, WNT, which is known as WNT. That is another developmental pathway.
I see.
There's a mutation, it goes wrong, and the children get these medulloblastomas. And the quirky thing about that one is that they respond very well to treatment and they do very well. And so the emphasis for those children is, well, can we take away some of this harsh treatment for them? But again, so the sort of average age of a child with medulloblastoma is like 6 or 7. That's the average age. But it goes from young babies. So we recently finished the child's treatment. We had a sonic hedgehog one, and I think he would have been about 6 months old, 7 months old when he came to us. And I've had patients that young adults that are in their sort of late teens. And very different looking after a 6-month-old or a 17-year-old. Their needs and their tolerance of treatments is quite different.
And how do they present? Like how a 6-month-old presents? Like obviously, parents are concerned and bring them in. Versus, a 16-year-old, what do you see? What drives them to come and see?
The common presentation for medulloblastoma is, so these tumors form in the posterior fossa, so the back part of the brain. And so that part of the brain is actually quite small. And so if something is growing in there, it's going to cause symptoms fairly quickly. And there's nowhere for because the brain is a closed box, so there's nowhere. Once the pressure starts to build, there's nowhere for it to go.
Yeah.
And so the common symptoms for an older child, and by older I'm talking anything from 3 or 4, right up to will be headaches, particularly in the morning,
Okay.
and vomiting.
Okay.
And unsteadiness because it's affecting the cerebellum.
Okay.
So often the parents will describe the children as like a drunken sailor, because they stagger all over the place. If goes unchecked, then drowsiness, and then you'll go into a coma, because essentially what's happening is the brain is pushing down on itself. And in fact, I remember vividly a child I looked after when I was at St. Jude, and she was sadly misdiagnosed for a bit of time, which is not uncommon, because most local doctors might see one childhood cancer in their whole 30, 40-year career, because it's quite rare. And so most kids that come in with headache don't have a brain tumor or vomiting.
Of course.
Might have gastro, might have migraine or something, but you're not thinking brain tumor's not at the top of your list.
No.
And she was air-vac'd from St. Louis to St. Jude once they worked out what was going on. And she was in the process of what we call coning, which is the way the brain is pressing down on itself. It presses the brain stem against the hard part, and eventually the body will shut down and you die. And I always remember the surgeon telling me, so he went in urgently because you have to have the child facing down to do the surgery. And he was trying to obviously going quickly to remove the mass that was causing this to happen. And she arrested, so he had to flip around, do cardiac massage. They got her back, and then they put her back, took the lump out, and she survived and has done really well. She's in her 20s now, has got several children. But you see how it can be very dramatic. And often by the time they present, the symptoms have been around a while, because nobody's thinking, you've got a brain tumor, of course.
The first thing you should be thinking about, really. First point.
And they're obviously trying to rule lots of other things out before they get to that point.
Now, babies very different. So babies obviously don't walk if they, so that you can. So babies is usually the head expands. The fontanelle can become tense. Irritability and vomiting. And sometimes, again, with this pressure phenomena, you can sometimes see what they call sunsetting eyes, because you get, because of the pressure in the brain, the eyes are unable to look up. And so you see the whites of too much of the eyes. It looks like a sun setting. You have to be quite astute to pick that up, but that's how we train doctors to pick up babies if they... as one of the signs of intracranial pressure is the sunsetting sign. So for babies, it's much more non-specific because they're not doing much to be able for the parents to be astute. But usually they'll be, quite irritable because they've got headache, basically. But they don't tell you, I've got headache. They just cry. And then they'll vomit, which is, again, quite common in babies because they often got a bit of a reflux or something. But if the head expands, and so it's a bit more forgiving because they're able to expand their head a little bit more if they're under 12 months.
So interesting.
Isn't it? Yeah.
So then, Dr. Nick, once it's been confirmed that it is a cancer, what kind of treatment then do these children go through? You talked just then about some obviously surgical options, but what's the treatment plan look like?
The first thing that would happen would be that the child would have a brain scan. That might start with a CT, but would rapidly be a MRI because that is much more accurate and much more detailed. And you have to actually do the MRI, not just of the brain, but of the whole spine as well, because these tumors, medulloblastomas, about 30% of the time can spread. And they spread outside from where they're born to other parts. It's like sending out seeds. And it makes a dramatic difference to the treatment for that child and the prognosis. So you need to know that. So that starts with the scan. And the first port of action is they're admitted under the neurosurgeons. Not infrequently, they have to put what they call a ventricular drain in to decompress the pressure. Often, because they don't as a rule, like to go and operate emergently, like if it's 2 a.m. or whatever. Things are often done better under controlled conditions.
Yes. Sure.
So often if these children come, they've got very high pressures and they'll put a ventricular drain in.
Yeah.
That buys time because then you've got the ability to work the child up, obviously talk to the parents.
Yeah.
We don't know at that stage exactly what tumor they have. You'll just know that they have a tumor. You don't know whether it's going to be a medulloblastoma or an ependymoma or a pilocytic. I mean, there are so many different types. You can speculate and there are features you can pick up, but ultimately it's only when you take it out.
Yeah.
The treatment journey and the diagnostic journey are in parallel at the beginning. So the surgeon has a very critical role in ideally trying to remove the tumor in its entirety.
Right.
They clearly can't remove every last cell, but where possible and where safe, they will try and remove all of the tumor, or at least as much as they can. That then is therapeutic in itself, in that it's critical for the treatment of that child, but it's not enough.
No.
So if all you do is surgery, 100% of these medullos will come back.
Right.
And in fact, in the early days, when the surgical pioneers, they perfected, because this surgery is quite technical. And so when it was first, most of the children would die during surgery because they didn't have the right techniques and, they would bleed to death or, or the brain would be so damaged. But then they perfected these techniques and the children would survive these surgeries, only then to be, a few months later, the disease would have come back or have spread. And so then they realized that they needed more than just that.
Okay. Yeah.
And that's where X-ray therapy was born, radiation therapy. So that's the other component of treatment. Now, that depends on the age of the child because you can't just radiate any child willy-nilly because of the consequences of radiation. Radiation is a very powerful treatment, but it's also very damaging.
Yes.
The younger the child, and the bigger the area you've got to radiate, the more damage you're going to cause.
Right.
And medulloblastoma, as you may have picked up, I've just said, it has a tendency to spread. So you can't just treat that local area. You have to treat the whole brain and spine.
Right.
Hence where the word craniospinal radiation comes in.
Right.
And it is a two-edged sword because of the damage that it can cause later in life if the child survives because of the developmental damage it causes. Yeah. So we titrate the dose to the risk of the cancer coming or the medulloblastoma coming back.
Yeah.
In that the top dose that you use for the ones that have the worst prognosis,
Sure.
but also it causes the most damage.
Yeah.
And by damage, I can rattle off a big list, but essentially, if you think your brain is your control box, it's your intelligence, it's who you are. And children that have had radiotherapy particularly when they're very young, will have reduced IQ, reduced processing speed, reduced memory, often inattention, like an ADHD-like disorder.
Wow. Okay.
And it makes it hard for them to function in life, actually. Many of them can never really function independently. Yeah. Hence why, it's not just about curing these children. Yeah. It's actually about curing them, but with dignity and quality of life afterwards, which unfortunately not many of them don't have. In the quest to get rid of it, we do a lot of damage. And so chemo came along and helped us reduce the amount of radiation for some of the children.
Okay. Yeah.
And now that we understand the diseases more, we now know that some types don't need as much treatment as others because not all medulloblastomas are the same. Like I alluded to earlier, the Wnt type, there's been 3 major international clinical trials that have all tried to do the same thing over the last decade. The St. Jude group, where I trained, my study from the Children's Oncology group, and then a study by my dear friends in Europe. We've all done roughly the same thing in our own jurisdictions by reducing the amount of this radiation to the whole brain and spine and reduce some of the toxic chemotherapy as well. All those studies now are gathering the data. They've all closed. We've all recruited. Sadly, it's the least common type. It's only 10% of medulloblastomas. So only 10% of children have we been able to reduce the amount of treatment.
Yeah.
But so far, early data suggest that we seem to be able to do it without compromising survival. Because the last thing you want to do is obviously you give less treatment, but then they all relapse.
Yeah. Yes.
Well, you're defeating the purpose.
Yeah. That makes sense. And Dr. Nick, I think that speaks really beautifully to what we spoke about in your intro around collaboration and how, all of these centres doing this work need to work together.
Yep.
And it's something that we talk about a lot, with rare diseases, with cerebral palsy, because we're talking about such a small percentage of the population. And then once you go, take it down another level within medulloblastoma, there's so many different presentations and types of medulloblastoma. You're simply not getting, if you're working in isolation, you're not getting enough data, really, are you, to be able to answer these questions in full? So it really has to be a collaboration and a team effort, doesn't it?
That's exactly. And look, Perth was actually the first of the Australian hospitals. So Perth, or Princess Margaret's as it was the first outside of North America to be admitted into the Children's Oncology Group, which was a group of American hospitals that all realized that you had to work together because one hospital doing things alone would never have enough numbers. It's just not possible. And so progress would have been held back had it not been for my forefathers, the pioneers, deciding that put aside egos and empires and all that, and actually, no single hospital, no single country could do it alone, and that you had to work together. And increasingly now we're seeing trials where it's not even just Australia with North America, because Canada joins in as well, but increasingly we're looking towards doing transatlantic trials, so even working with the Europeans, because for the very, very rare types of tumours that we're discovering, you need global collaboration. And it can be a challenge because people come at a problem with different perspectives, like the French might say, well, we like using this type of chemo in this scenario, and we like this type of radiation. And the Americans say, no, well, we like it like it. So you have to compromise. And it's not that one is right, one is wrong. Is they're probably both right, but they've each attacked the problem from a slightly different perspective. And if we're careful and do it properly, you can actually end up picking the best of both worlds. What you don't want to do is pick the worst, the worst of both worlds. But that's what we're trying to, because the numbers just aren't there. And Australia realized long ago it does not have the population to run these trials by itself. It just doesn't have it. And so we are probably, and we're highly respected internationally, and highly praised for our collaborative. We are very collaborative and always have been. It's almost our ethos because we recognize we never could do it alone. And so for decades now, we have been collaborating with the Americans and the Europeans on a variety of clinical trials. That way our children here, and I say to the families when they're diagnosed, I said, the treatment that I'm offering you here, you would be offered in New York, you would be offered in Los Angeles, you might be offered it in Heidelberg. We're not, yes, we're the most remote city, capital city on the planet, but we're not backward. We actually are cutting edge just like everywhere else because we're
You're not disadvantaged.
Not disadvantaged. It's important that families hear that because Perth is a gorgeous place, but I think sometimes people underestimate how good the Perth actually is and the therapy they can get. And I'm not just talking about cancer, I talk about the Children's Hospital houses amazing individuals, very dedicated and very highly connected internationally. We have one of the best respiratory programs on the this
probably happened because we've had to. And that's
necessity.
Probably a really good, and in doing so, it's health equity. Like it does come down to that, isn't it? So on that then, in terms of, what we often see is on the other end, but what is the prognosis? Like how many of these children get through the treatment, and what does it look like for them afterwards?
Yeah. Okay. So both very good questions, and of course, it's what the parents want to know.
Yeah.
It very much depends. There are a number of factors it depends on. So if you look at medulloblastoma overall, the prognosis is quite good. It's one of our better brain cancers in terms of survival.
Right.
It's around 70% overall.
Okay.
But that figure means very little to that individual
Sure.
because it depends on their age. It depends on the stage of their tumor. Is it localized? Is it spread? Is the surgeon able to get it all out, or wasn't the surgeon able to get it all out? And then very much on, well, what are the genetic drivers of it? Which group does it fall in?
Right.
If it's a Wnt, I can tell you they're going to do quite well.
Yeah.
Okay, with a 90+% chance of survival.
Okay.
Yeah.
But if it's a hedgehog with a P53 mutation, it's a very, very small chance of survival.
Wow.
So you can go almost from close to 100 to close to 0 with the same disease, the same name, medulloblastoma.
Yeah.
The treatment, unfortunately, remains a blunt instrument. We're still reliant on what I've just talked about, the surgeon, the radiation, and these very toxic chemotherapies, which without the treatment package, the survival would drop away. And I'll give you a very good example of that. The treatment is critical even for the underlying molecular abnormalities. So if it's really, really bad, the prognosis, and you're throwing absolutely everything at the child, then you clearly have to find something else to do.
Yeah.
If you're doing very, very well, like I said, you can start to reduce some of the amounts of treatment that you're using.
Yeah.
But if you do it too much, if you go too far, the child will relapse.
Yeah. Okay.
If they relapse, their chances of survival, if they've had radiation, is essentially 0.
Oh, wow.
So you have to be very careful.
Yeah.
And there were a couple of trials that ran internationally where, again, very well-meaning, it was with the right meaning in place, where they tried to remove radiation in its entirety, or they tried to only do radiation to the back of the brain, because what's really damaging is the radiation to the whole brain and spine. On the Wnt subgroup, because they do the best.
Yes.
Yeah.
So maybe they don't need radiation.
Yes.
Maybe they only need a little bit. Complete failures. Okay.
Wow.
In the one where they removed radiation its entirety, all the kids that would, and luckily they stopped the trial very quickly because they realized these kids are relapsing.
Yeah.
They managed to rescue a good portion of them,
Right.
but they had to essentially double the dose that they ended up giving in the end. And then of the ones where they only got the radiation to the back of the brain, the survival dropped to 50%. So from 90 plus to 50. So again, that trial got shut down.
Yes.
What does that tell you? It tells you that craniospinal radiation is essential if you want to cure these children.
Yeah.
What we don't know is how low can we go on the dose. That is the key. And we have managed to now drop it to quite a low dose.
Okay.
We'd like to probably go low, but there will be a threshold at which point you are not killing those cells.
Yes.
And the problem is, once you've exposed those cells to that radiation, you can't then rescue them, is the problem.
Right.
You can't just say, oh, well, I'll give you the bit that you missed later.
Yeah.
So that's the problem. That's the problem. Yeah.
Such a balancing act.
It is a
isn't
very, very careful balancing act.
Yeah.
And the only way you can do it is to collaborate.
That's right.
And have these very large studies.
Yeah.
Because if you're trying to do it just Australia, it'll probably take you 50 years.
That's right.
You just wouldn't have that.
You wouldn't get the advances.
No. There's not enough patients.
No.
Yeah.
Yeah.
But the ones it affects, it's a significant impact on quality of life for them and the whole community.
Yeah.
isn't
Well,
it?
that's where your second question, I guess, was, well, for the survivors, well, what's life like?
Yeah.
Again, it depends on how much radiation they got
Sure.
and what age they got it at.
Yeah.
Also depends on, did they have some damage as a consequence of the surgery, which can leave them, and Dana, here working, that there will be some children that get something called posterior fossa syndrome or cerebellar mutism, which is a disorder which remains an enigma. We don't really understand it.
Right.
But some children, when you remove these tumours, which is absolutely essential for their treatment,
of course.
But they can get this damage in the pathways that connect the cerebellum to the rest of the brain, and they can be very damaged from it. It can impact their ability, so they often can't speak, and it takes a while for their speech to come back, but then it's never quite normal. They're often very, very, very wobbly on their feet, and may even have, paralysis and inability to stand, walk, or anything. So, and also it affects their lability. So they're often become much more different personality than what they were. So they will get angry quicker. They will have outbursts. They'll be more difficult to console. And that's because the connections have been. It often improves and can improve quite markedly, but it generally does leave disability. The other big one, as I talked about earlier, is for the young children, especially if they get the bigger doses of radiation, it has a massive impact on intelligence and, like I said, processing speed and memory. And then there are the physical. It affects the hormones. Your hormone control centers in your brain, and so a lot of them end up on multiple hormone replacement therapies. It affects growth. It affects your thyroid. It can affect your puberty. You can go into puberty too early, we call precocious, or you don't go into puberty, so then you need hormone replacement type therapy and support. It can impact heart health, lung health. Often these children end up much shorter. They're disproportionately short because we've radiated their spinal columns. Their arms and legs are longer, but they've got a short spine. They often have hearing problems. Many of them are deaf. In fact, I generally tell the families, please expect that they'll need a hearing aid because of the chemo and the radiation. There's a whole host. I mean, those are the sort of the main ones that come to mind.
That's what you're always balancing, isn't it? In the entire time, that's what you've got to balance.
Yes.
Wow. Okay.
So we're cognizant of this.
Yes, of course.
But unfortunately, if we want to cure them, that's what we are. We have tried to replace radiation with very, very intensive chemo, and that's what we will do for the little babies. So if you're free and under, or under free, we generally will not radiate your whole brain and spine. I say generally because you can't have fixed rules for anything. But we, as a rule, we will not radiate under 1, and then we'll start to do focal from 1 year upward. Again, it depends what part of the brain, the size of the tumor. And there are different types of radiation. Some of our children now go overseas for proton therapy. It's a bit more targeted, so causes less collateral damage. But, if you're radiating the whole brain and spine, by definition, even if it's more targeted, you're still affecting the whole brain and spine. So that, yes, there are some advantages to protons over photons for the whole brain and spine, but they're not to the brain itself so much. But less of it might come through to the lungs, less of it might come through to the heart. It's quite complex, the litany of problems that survivors will have, and many of them will have a lifelong problems with their health as a survivor of cancer, unfortunately. And brain cancer, because it's your control box, disproportionately affects them more than, say, if you've survived leukemia. So, leukemic survivors, unless they were really, really very, very young, we don't generally use radiation in leukemia anymore. There are a couple of exceptions to that rule, but and you cross them in the street, you wouldn't know they had leukemia. You can tell if a child had brain cancer. You will tell.
And it makes sense logically when you think about how complex the brain is and how many different processes and systems are developing in that really vulnerable period of child development. I suppose, lots of our listeners are allied health clinicians, and so they might be wondering, what are the really crucial pieces of information if they are working with survivors of medulloblastoma? What kinds of things should they be thinking about and considering when they're working with these families and these children. Dana, you might be able to speak to that as well as someone who works with these kids.
Yeah, I mean, just hearing you talk through all of the things that they need to be able to deal with is really interesting as well. And for sure, from our side, it is looking at ADLs, how can they function? Yeah. There's a lot of adaptations that are required, but there's also great scope for strengthening and even just almost gaining some of their strength back and their fitness back, because they are just so deconditioned after it, isn't it? So in the early days, it's just
grueling.
It's strength. It's giving them the opportunity to put on some weight. It's, all of that first. Then looking at adaptations for ADLs, I think that's really essential. But I've seen the range as well here. I've seen ones who have just walked out the door and are doing really well and have jobs, and I've got others who kind of look to them and go, oh, but I'm still using a walking frame. And I go, it's important to keep you up. It's important to keep your strength upright. So there is that range. I have seen it on our side.
No, exactly. Yeah. I mean, if you radiate, if I'm radiating a 16, 17-year-old, I'm not going to impact his intelligence or her intelligence. It still has some impact.
Processing,
the processing speed is still impacted because you're still affecting your normal neuronal connections, but you're not affecting development. That's the key difference. And so the impact is there, but it's nowhere near as profound. The ones that have the biggest impact are you're under 8s, where the brain is at its maximum going through that development. And the ones that we see the biggest problems are the 3 and 4-year-olds that get. In fact, in Europe, for example, they try and avoid radiation. So the definition of infant depends where you are in the world. Okay. In America, it's under 3. In Europe, it's under 5. Some clinicians even use under 10. But that's just because it's a bit of a stretch. But I think the principle being
I get it, though.
That they're recognizing that there's a big impact. The problem is that chemo, most of the young children that get what we call radiation-sparing chemotherapy will eventually end up needing radiation at some point. What you've probably done is delayed it for a while.
And allowed some of those...
Development, And we say any delay can be useful. Where it gets tricky is if you absolutely know someone is more or less going to relapse, you know, as soon as you stop that chemo within 6 months. And then they end up with a big dose of radiation. One of the studies that we're doing in collaboration, it's led by St. Jude, is a stratified dose of radiation. So the study is saying is the vast majority are going to relapse and end up getting the top dose, and they will already have had this heavy-duty chemo. So it's almost like you're giving them a double whammy. So what their principle is saying is we'll give chemo right up until they're free to keep the cancer at bay. But when they turn free, we will, instead of waiting for it to come back and then be more resistant and whatever, we'll just give the radiation. But we'll give it in a dose stratified manner. So if you've responded very well to the chemo and the features at the molecular level of the tumor are the less aggressive ones, we'll give you a lower dose. If you have at the more aggressive types where we know we're not going to cure unless we give you the top dose, we'll give you the top dose. And that approach is open as we speak. Obviously, you have to have it's informed consent, and you have to have the families be on board with it. Not everybody's comfortable with doing that approach because it's a pragmatic approach. It's saying that radiation is the best treatment, but it's also acknowledging that it's also the most damaging. So it's like a necessary evil, unfortunately, which is, I guess, what we're trying to do in the research sphere is to try and find treatments that don't, that are more specific and less damaging, so that we one day hopefully can either reduce dramatically how much radiation or get rid of it altogether. That's the holy grail. If we can cure these kids, 100% cure with no side effects, that's what we're aiming for.
For sure.
And everything you've described, I can see how it all fits. In a nutshell, I know this is pretty significant, so this is going to be hard to put in a nutshell. But you've been part of some pretty significant announcements over the last 6-8 months, I suppose, and I know you've been working on it for quite some time, and it's West Australia's first comprehensive kids cancer centre. I can imagine already everything you've just spoken about in terms of what you're part of, the collaborations, we all embedded into this centre. But can you tell us more about what this means for us here in Western Australia, but I guess globally as well? The contribution will be significant.
Yeah, look, I'm still literally pinching myself that this is even happening. It's been an incredible journey the last 12 months. Working, with the Stand Parent Charitable Foundation. They're just an amazing human beings, basically, with hearts bigger than, I don't know.
It's hard to describe.
Hard to describe.
It really is.
Their generosity
I get it.
is beyond description. And their vision is to transform childhood cancer in West Australia. But because of our collaborations, of course, it has an impact internationally.
Of course,
And where it stems from really is, I have to say, look, I trained at St. Jude Children's Research Hospital in Memphis, Tennessee. This was quite a long time ago now. It was between 2005 and 2008. I went there because I was advised by a very senior clinician that when you're training, you need to go to the best place in the world, if you can get in, obviously.
Of course.
And I was lucky. I got in. And what St. Jude brought was this sort of enmeshment of the clinic and the research together. There's no line of distinction. The children have and this is probably the place where you see it in action the most, in the cafeteria. You could have a child with bone cancer sat on a table with his mummy and daddy next to a Nobel laureate, and quite literally. And on the table next to that would be the clinician that wrote the chemo up and the radiation doctor that's radiating.
Wow.
They all work.
They're there together.
All together.
Yeah.
And that paradigm is something that I'd always wanted to replicate in Perth. And of course, I'm not the only one. We had been working behind the scenes on truly integrating research into the clinic. And once we moved from Perth, Princess Margaret to Perth Children's Hospital and what was then the Telephone Kids Institute, it's now the Kids, I can't even remember what they were called.
Kids Research
Kids Research Australia. It just changed names.
Just changed names,
that we're actually co-located. It actually... well, to me, it seems a no-brainer.
Yes.
But of course, it takes resources to do it. And we got to a point where if we didn't do it, we were going to stagnate.
Right.
So we had got to the point where we couldn't grow anymore within the shell that we had. And our ethos is, as I mentioned earlier, yes, we're the most remote capital city in the world. I don't want a mum or a dad bringing a child with cancer to us and thinking that they're getting substandard treatment or that they need to fly to Germany to get a better treatment. I want all those treatments to be here. And I want us also to be part of developing these new treatments. And we have, of course, worked together because I work in the lab as well as in the clinic. But it wasn't as part of this idea of this comprehensive where you break down all administrative, bureaucratic location barriers and you just create one system. And with the aim of bringing more trials to Perth and also being at the forefront of developing trials, because we've actually done that already, but doing it more efficiently. So comprehensive cancer centres are well described through evidence-based to produce better outcomes. So why wouldn't we want
it? Exciting. Congratulations.
It's amazing. Thank you. And it was a massive team effort, as you can imagine.
I bet. Absolutely. These things are always done in big teams. But I remember seeing the announcement and it was an eye-watering amount and I couldn't wait to talk to you. I'm like, how did this happen? So the story is definitely one to share for another day, but it's pretty brilliant and what that means. So thank you for being part of driving this huge initiative.
Thank you.
I suppose, ultimately it leads to better outcomes for children and their families.
That's what we want.
Undoubtedly. I think it will definitely lead to better outcomes for the kids of WA. And it may, it is very likely to impact children internationally because, as you know, we're so interconnected.
That's right,
Okay.
Oh, that was a great conversation. It's not done yet, though.
It's not.
Ed, I hope you're ready for this one because this will be a good one. Let's head into the final segment. Tell it to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening, pushing buttons, pushing faders. I don't even know what it is. Sliding faders.
Stay in your lane, Dana.
Stay in your lane. That's right. Let's just stay with that one, Dana. He's staying technical. But he has been listening, and I'm sure he's got a few good questions. But we're going to say just one question for now. I nearly let that one go. So before Ed has an opportunity to ask you a question, Dr. Nick, can you summarise the area, I suppose, of medulloblastomas in about 60 seconds or so?
Yep.
And Ed, you have time for a question. One question. Take it away, Dr. Nick.
All right. So medulloblastoma is the most common malignant brain cancer of childhood. It is composed of 4 distinct molecular subgroups, which each drive the disease in different ways. The treatment for it remains surgery, radiation for most kids over a certain age, and chemotherapy. Overall outcome is about 70%, but this varies markedly between the different subtypes, from 90 to 95% for the best, down to almost 0 for the worst, 10% maybe for some children. We're now at a point where we're looking for using the knowledge of the biology of the disease to develop more specific therapies that is more targeted to the subgroups, which will hopefully be more efficacious and less damaging, producing children with higher cure rates and less damage and better quality of lives.
Brilliant summary. The man can teach, and he can summarise a very complex area in 60 seconds. All right, Ed, over to you for a question.
So this is definitely where I think the streak for my ability to ask an intelligent question might come to an end. I thought it might have happened a week or two ago, but this one is probably there. With all apologies to the sound engineering community, what we do is definitely not brain surgery. So my question is probably in relation to the damage that therapies and interventions can kind of do, whether it's the surgery or radiation therapy. And I'm a tech kind of guy, so my question is kind of vaguely tech related, and it's definitely tangential, so I'm going to get there. My question was about things like new technology like Neuralink. And obviously the podcast is a non-partisan, no political side of the equation kind of taking podcast. But companies like this particular one have obviously invested money into developing devices that can kind of intercept brain signals. And I wonder whether that type of thing can have an impact on recovery, or like the way radiation therapy might be perceived or considered when it comes to other things that might be able to assist in that recovery.
No,
I don't know if I'm asking a good question.
It's actually a brilliant question.
The streak continues.
You're far too kind.
So it's very insightful. I'm not familiar with the specific company you're referring to, but what you're basically describing is neurorehabilitation. So, and in fact, of course, the obvious thing is to remove the radiation. So if you don't have the thing that causes the damage, you won't get the damage. But if we do that, we drop cure rates dramatically. Yes. So then what's the other things you could do? Well, you could do things, can you neuroprotect during treatment? So in other words, is there something you can give that will protect the good brain whilst the radiation kills the cancer? And then the other strategy is, well, okay, you've caused the damage, you've damaged us, the good cells, but can you help them recover and rehabilitate? And there are definite areas where it looks promising that we can neurorehabilitate and help the brain heal so that the children aren't left with as much damage. So there are some trials at the moment. There's one using the anti-diabetic agent, metformin, where researchers in Canada saw that it helped the neurons, if you like, reform, and it helped the stem cells sort of reform parts of the brain that were damaged.
Wow.
So that's now being tried. There are other chemicals, drugs that are given during radiation. One example is mementine, which is designed as a neuroprotectant.
Right.
And other areas are where you try and get the children to do brain exercises whilst they're receiving. So a little bit like how important exercise is during chemotherapy, that we know it makes the children tolerate it better.
Yes.
It's kind of almost common sense that your body was designed to keep moving.
Yes.
Well, the brain is designed to think and whatever, and form these neurons. And of course, the more it's doing, the more these neurons connections are forming. And so some neuropsychologists are working on strategies to help the kids during the radiation to keep the brain active by doing brain exercises.
Yeah. Okay.
So there are definite areas, and so you're right onto it there. Good on you.
He looked relieved.
I was sweating.
I feel
that was a great question.
I feel like we could talk for another hour about
thing, isn't it?
Neuroplasticity and.
Well, we're holding a symposium in Canada in middle of the year. I was asked by this charity that actually is traditionally focused on DIPG, diffuse intrinsic pontine glioma, which is universally fatal. It's a terrible tumor. Some of the parents of children that had passed away started some charities, foundations in the US, called the Cure Stats now, and they've held these symposiums every 2 years focused on that disease. But they now want to branch to medulloblastoma. And so we asked the families, what would you like us, because we're bringing world experts, so what would you like us to focus on? And one of the areas was around posterior fossa syndrome and neurorehabilitation.
Wow, okay.
So it'll be centered around that because, of course, quality of survival actually is arguably as important as survival. Although a parent at the beginning of the journey, they're just focused on, obviously, on survival.
Of course. Yeah. No, that makes sense. Dr. Nick, I feel like we could keep talking to you for hours, and I hope that one day we'll be able to align our schedules again and you'll be able to come back and dive into some of these other things we've touched on, because I feel like there's so much here and it's so interesting. You explain it all so beautifully.
Great teacher.
Yes. Thank you for
thank you for having me.
Thank you for bringing us on that journey today. And I feel like there's lots more questions that I would like to them down. Pick your brains
for next
about.
time. For sure. And look, to all of our listeners, we'll put links to Dr. Nick's profile and all the publications he's been part of as well, and you can follow the symposium. So head to researchworks.net to do that. Yeah. But for now, we'll say thank you very much, and we'll talk to you all again really soon. Bye.
Thank you.
Bye.